Good morning. Thank you for being here again today, and I would like to thank Roche for organizing this satellite symposium and for asking me to discuss with you the biological tools and how we use now these biological tools to monitor HIV therapy in the era of direct-acting antivirals. In the first part of my presentation, I will review with you the different biological tools that can be used to diagnose and monitor HCV infection. And the first set of tools are tools that help us determine the HCV genotype. As you know, there are 6 HCV genotypes that have been described. This slide shows you a phylogenetic tree. And if you look at the tree in the middle, I'll use this one, yes, because I have an arrow. This is when the diversification of virus started, and you can see here this phylogenetic tree showing the Darwinian diversification of the virus that started something like 1500 years ago. 6 main genotypes and a very large number of subtypes, genotype 1, 2, 3, 4, 5, and 6. The subtypes are very many if you go to the region of origin, but the subtypes that have spread over the world are not that many, and you know that most patients are infected with genotypes 1A, 1B, 2A, 3A, 4A, and 5 and 6 are extremely rare. There are several methods to determine the HCV genotype. Most are molecular. It can be based on direct sequence analysis, homemade sequence analysis in labs, analysis of the NS5V region, of the envelope 1 region. But there are also commercial assays that are based on direct sequencing. This can be based on direct sequencing of the 5' non-coding region. TrueGene has an assay, or of the NS5V region, which is more reliable, and TrueGene also has an assay for that. Second group of methods to determine the HCV genotype are real-time PCR methods with genotype-specific primers and probe. But the most widely used technique for genotyping is reverse hybridization of PCR products. This is called the line probe assay, and currently the second generation line probe assay is available. There were also serological methods, but I believe now nobody is selling this kit. It was okay, but not as good as molecular methods. So I just mentioned the Inolipa assay version 2. This is what it looks like. It's nitrocellulose strips, and they have probes that have been fixed on it. The principle is to do a PCR to amplify the genome and then hybridize the amplified genome onto these strips. And as you can see, there are probes for the 5' untranslated region. But what is very important here is that the second generation of the assay also has probes for the core region, and the combination of both show different profiles that allow you to identify the different genotypes, especially to differentiate very well by means of the core region probes, genotype 1A from genotype 1B. And these are the results of a study we published a few years ago with Stéphane Chevalier, my collaborator, and you can see here that we assessed the performance of different genotyping assays to discriminate genotype 1A from genotype 1B. This is sequence analysis of the 5' non-coding region, the first generation of the line probe assay, which only had probes in the 5' non-coding region, the second generation line probe assay I just mentioned, and a real-time based assay from Abbott. We had 2 groups of patients who were infected with genotype 1A and patients who were infected with genotype 1B. And what is interesting here is that you can see that sequence analysis of the 5' non-coding region was correct in only 77.6% of cases for genotype 1A, 90% of cases for genotype 1B. The first generation line probe assay, 70% for 1A, 91% for 1B. The problem was not the assay itself. The problem was the region which is targeted, which does not allow for good discrimination of genotypes 1A and 1B. In contrast, if you use a second generation line probe assay, here you can see that the accuracy of detection was 97.5 and 96.2%, and this means that this assay is the best assay to identify the genotype and the subtype. Is there any interest in subtyping, identifying genotype 1A and differentiating it from genotype 1B? For therapy based on peginterferon ribavirin, there are no practical interests for making clinical decisions. For triple combination therapy with interferon, ribavirin, and protease inhibitors like telaprevir or boceprevir, there is a modest difference in genotype 1A and 1B in terms of sustained virological response. There are different resistance profiles, but there is no clinical interest because you will not change your clinical decision based on genotyping. In contrast, for interferon-free regimens, it could be important in the future, especially because some combinations will be more suited to genotype 1A or genotype 1B, and this we'll know in the future. That was for HEV genotyping. Let's now discuss HEV RNA quantification, detection and quantification. This slide shows you the dynamic range of quantification of assays that have been used for many years in various labs. And you can see here that this range of quantification, which is a range of values which are accurately quantified, was much too narrow. These assays were not able to quantify high viral loads, which are found in many patients, especially this gray area you see here, which is where 95% of the patient had their viral load in the absence of any treatment. And the assays were not sensitive enough to detect very low levels of replication. So new assays based on real-time PCR were developed, and as you can see here, these assays have a great performance. They can cover the full range of clinical values that are observed in our patients. They quantify accurately very high viral loads on the right and go down to very low level on the left, and they are very well suited to tailoring treatment duration and assessing the virological response on treatment. A few examples. This is the Abbott real-time PCR assay, and you can see here that there is an excellent correlation, whatever the HEV genotype, between the values obtained with the Abbott assay and a reference assay based on another technology, branch DNA. The other very widely used assay is the CAP-CTM assay from Roche. This is a picture taken from a paper we published a few years ago with a first-generation assay, and this first-generation assay had a problem. You see here a very good correlation with the values, but here some of the values for genotype 2 and 4 were too low, and when we looked at the difference, we observed that this assay, first generation of the Roche assay, was underestimating a substantial proportion of viral loads in patients infected with genotype 4. And we even identified 2 patients here who had undetectable HEV RNA with the Roche assay, but detectable high-level HEV RNA with the branch DNA assay and the real-time PCR assay from another company with high viral load. So there was a problem with this first-generation assay. The company worked on this problem, and they developed a second-generation assay, which is now available. It's a real-time PCR assay, Roche version 2.0. And you can see here in this paper, which has been published very recently from our group, that this assay now very accurately quantifies HEV genotype 4. You can see here an excellent correlation between the values obtained with the Roche assay and the values obtained with the reference assay. Excellent correlation. That was true for many different subtypes of genotype 4. And we also had 4 patients who were undetectable with the first generation assay from Roche, but were very easily detected and accurately quantified with the second generation assay, as well as with the Abbott real-time PCR assay and the reference assay. So now the Roche version 2.0 assay is a very good assay for HEV RNA quantification. There is another group of techniques based on HEV core antigen quantification that have been used as surrogates for HEV RNA replication. The reason is our old publication in 2002, where we showed that there is a very good correlation between the HCV RNA level in the x-axis and the HCV core antigen level on the y-axis. Meaning that if you measure core antigen in blood, you indirectly measure the level of viral replication. And this correlation is seen in individual patients, and if you look at the viral kinetics in patients in which have been measured with an HCV RNA assay here or with a core antigen assay, you see that the curves, the slopes are exactly the same. At the top left, you have a patient with a rapid virological response, who has a sharp decrease of viral replication, and you see that the core antigen is going in parallel and becomes undetectable, achieves an SVR. On the right, you have an SVR patient. At the bottom, you have a relapser, a non-responder. You see that the curves are really parallel, and therefore, core antigen quantification could theoretically be used to indirectly monitor HEV replication. However, if HEV core antigen quantification could be used as a surrogate marker of replication, it lacks sensitivity. And if you compare it to the HEV RNA level quantification by real-time PCR, the lower limit of detection of the core antigen assay is of the order of 500 to 3,000 international units per ml. And the decisions we have to make in clinical practice are based on cutoffs which are of the order of 15 to 20 international units per ml. And this means that core antigen quantification can be used to diagnose infection. It's sensitive enough to diagnose an infection with a high viral load, but it's not sensitive enough to monitor replication on treatment and to make clinical decisions such as the ones I'm going to show you now. So core antigen quantification cannot be used to replace HEV RNA level monitoring by real-time PCR. In this first part, I wanted to show you the assays and the tools we have. I would now like to discuss with you the practical use of these assays now and eventually in the future. First of all, for patients who are not infected with genotype 1, the current standard of care is not new. It's still the combination of pegylated interferon and ribavirin, and we're still using this very simple combination we've been using for 10 years for patients who are non-genotype 1 infected. And for monitoring this treatment, we have to use several time points: baseline, week 4, week 12, and week 24. And with these 4 time points, it's possible to really draw guidelines. And if you look at the EASL clinical practice guideline, they will tell you the following. You will first look at what happens at week 12, and a patient who has a less than 2 log viral load decline at week 12, in yellow here, is a patient who has no chance of achieving a sustained virological response. This is true whatever the HEV genotype, and a patient who has a less than 2 log decline at week 12 should stop therapy. Now the patients who have a more than 2 log viral load decline can split into several groups. Patients who have a rapid virological response, these patients have an undetectable HEV RNA at week 4 of therapy, and in that case the duration of treatment is 24 weeks. This is true for all genotypes, especially if they have a low baseline viral load. The second group of patients are the patients who have an early virological response, detectable HEV RNA at week 4, undetectable HEV RNA at week 12. In that case, the treatment is 48 weeks, whatever the HEV genotype. This is true as well for genotypes 2 and 3. You may think that genotypes 2 and 3 must be treated for 24 weeks only. If the patient is still with a detectable HEV RNA at week 4, you have to prolong therapy until week 48. And this has been proven recently by papers that has been shown at the AASLD meeting, showing that the patients here were genotype 2 and 3 patients without a rapid virological response were randomized into receiving 24 weeks of interferon ribavirin in red or 48 weeks of interferon ribavirin in green. As you can see in the ITT analysis, there was a 10% benefit for 48 weeks, the per protocol analysis 10%, and in study completers, the difference was highly significant. 54% of the patients with 24 weeks achieved an SVR versus 73 with 48 weeks. So please remember that patients who do not have an RVR must prolong therapy for 48 weeks, whatever their HEV genotype, if you use interferon and ribavirin only. And finally, if the patient has a more than 2 log drop at week 12, but is still with detectable HEV RNA at week 12, and this patient has undetectable HEV RNA at week 24, the patient should be treated for longer time, should be treated for 72 weeks, and this patient will benefit from the 72 weeks of therapy. And this is very important, that you should not hesitate to prolong therapy in patients who are slow virological responders or delayed virological responders. That's for the current standard of care for genotype non-1. What about genotype 1? Genotype 1 was discussed yesterday in the session, and you know that we currently treat genotype 1 infection with a triple combination of interferon, ribavirin, and either telaprevir or boceprevir, a protease inhibitor. And here we will have two different monitorings for the two different drugs. This is what we do with telaprevir, and as you can see, what we do with telaprevir is very much the same as what we did with interferon ribavirin alone. Baseline assessment, week 4 assessment, week 12 assessment, week 24 assessment, and then the indication of therapy is here. Two groups of patients, treatment naive or responder relapsers on the one hand, partial responders or non-responders on the other hand. If you look at the treatment naive or relapser patients, they will have response-guided therapy. This means that they will be treated for 12 weeks with a triple combination of interferon, ribavirin, and telaprevir. This will be followed by 12 weeks of interferon ribavirin alone. If the patient had an extended rapid virological response defined by an undetectable HEV RNA at weeks 4 and 12, treatment will be stopped at the end of the 24 weeks period. If the patient did not achieve an ERVR, the patient still has detectable HEV RNA at weeks 4 and or 12 that remains below 1,000 IU per ml. The patient will continue with interferon and ribavirin for an additional 24 weeks and will stop at week 48. A second group of patients, partial responders or non-responders to a prior course of therapy. In that case, it's very simple. It's not response-guided therapy. It's very simple. Everybody will have the same. 12 weeks of the triple combination of interferon, ribavirin, and telaprevir, and then the patient will be switched to interferon and ribavirin alone until week 48, and that's it. There are stopping rules, futility rules, and treatment should be stopped in these patients because there is no chance of a sustained virological response if the HEV RNA is above 1,000 IU per ml at week 4 or at week 12, or if the HEV RNA still is detectable above 10 to 25 IU per ml at week 24. And these futility rules have been checked. They have been validated in a retrospective study. That was a retrospective analysis of the ADVANCE, ILLUMINATE, and REALIZE trials. It's data on 900 treatment-naive and 270 treatment-experienced patients. And you can see here that the likelihood of a sustained virological response if the HEV RNA at week 4 was above 1,000 IU per ml was 0%. No chance if you're above 1,000. But if you are between 100 and 1,000, the SVR rate was 22%. And this really tells you that above 1,000, the patient has no chance of achieving a sustained virological response. You can stop therapy. The same was true at week 12. HEV RNA at week 12 above 1,000, 0% SVR. HEV RNA at week 12 between 100 and 1,000, 15%. If you are between 100 and 1,000, you can continue. Your patient still has a chance of achieving an SVR. If you're above 1,000, you should stop therapy. And the reason is explained here. You can see here the HEV RNA profiles in patients with HEV RNA above 1,000 IU per ml at week 4. All of these patients who had more than 1,000 IU per ml were patients who initially responded with a sharp decline of our replication, and then there was a re-increase of our replication. So if you have more than 1,000 IU per ml at week 4, it's not that you are slowly declining, it's that you decline initially, but you have a virological breakthrough. And this clearly illustrates the fact that there is no chance you can eliminate infection because you are failing already at week 4. What about boceprevir? Boceprevir is a little bit different. The reason is that for boceprevir there is a lead-in phase. The lead-in phase is 4 weeks of interferon ribavirin. Therefore, the assessment will be done at baseline. The second assessment is done at week 8, which is week 4 of boceprevir administration. 4 weeks of lead-in plus 4 weeks of boceprevir, week 8. Then week 12 and week 24. And the indication is a little bit more complicated. There are 3 groups here. Treatment-naive patients excluding cirrhosis. Treatment-experienced patients excluding non-responders and cirrhosis. And finally, all the cirrhotics and all the non-responders are taken together. In treatment-naive patients who do not have cirrhosis, this is response-guided therapy. The patients are treated with the lead-in phase, interferon and ribavirin 4 weeks. Then boceprevir is added. It's added, and at week 8 there is an assessment. Continues until week 28 if the HEV RNA at week 8 is undetectable. These are the early responders, rapid virological responders. If HIV RNA is still detectable at week 8, the patient will continue with the triple combination of interferon, ribavirin, and boceprevir until week 36, and they will then stop boceprevir and be switched to peg interferon and ribavirin alone until week 48. This is the only group that has response-guided therapy. The second group, treatment-experienced patients, excluding non-responders and cirrhosis, have the lead-in phase with interferon and ribavirin for a week. They add boceprevir, continue on triple combination until week 36, and then stop boceprevir, continue with interferon and ribavirin for 12 additional weeks. And finally, for the cirrhotic patients, all the prior non-responders, it's very easy, very simple. The patients are treated with the lead-in phase of 4 weeks, then boceprevir is added, and then the triple combination is continued until week 48. So the response-guided therapy, the use of HIV RNA monitoring, is useful only in the treatment-naive patients who do not have cirrhosis. All of the other patients should be treated with a fixed dose and duration. There are futility rules as well, stopping rules. They are a little bit different from the stopping rules with telaprevir. I told you that for telaprevir, the threshold for stopping treatment was an HIV RNA above 1,000 at week 12. For boceprevir, it is an HIV RNA above 100 IU per ml at week 12, or an HIV RNA which is detectable at week 24. And this has been again validated in a retrospective study, including treatment-naive and experienced patients. In the SPRINT2 trial, which was the study with treatment-naive patients, none of the 65 patients with an HIV RNA above 100 IU per ml at week 12 achieved an SVR, 0%. In contrast, 49 out of the 79 patients with detectable HIV RNA below 100 IU per ml at week 12 subsequently became HIV RNA undetectable, and at the end 43% achieved an SVR. Clearly tells you that 100 IU per ml is a threshold to decide to stop treatment. If you're above it at week 12, no chance of an SVR. If you are below it, still a reasonable chance of an SVR. And the same was true in the RESPOND2 trial in treatment-experienced patients. Only one patient with an HIV RNA above 100 IU per ml at week 12 achieved an SVR, and 5 out of 6 patients, 83% with detectable HIV RNA below 100 at week 12, subsequently achieved an SVR. 100 IU per ml is the appropriate threshold. Finally, what will happen with future therapies? Will we still use HIV RNA load monitoring? Will we still use treatment duration tailoring based on this? For me, the answer is probably not, and the reason is very simple. I will just show you 2 examples. This is a study that has been shown at the ASLD, and more recent data have been shown at the EASL meeting. It's a combination of sofosbuvir, this is a Gilead nucleotide analog, and daclatasvir, this is an NS5A inhibitor with or without ribavirin, in treatment-naive genotype 1 patients, and you can see here that the SVR rates in this study were 100% for 12 weeks of administration. When you have such high rates of response, why would you use HIV RNA load monitoring? You don't need to do it. Just treat your patients. Of course, in real life, it will not be 100%, maybe over 90%, but treatment will be very simple because the rates of SVR are very high, and I don't think we will need to use HIV RNA load monitoring any longer. The same is true with another combination. This is a triple combination that AbbVie is developing with ABT450, the protease inhibitor, ABT267, the NS5A inhibitor, and ABT333, the non-nucleoside inhibitor, the Aviator study. And you can see here that if you use these drugs all together with ribavirin, the SVR rate is 97% in treatment-naive patients. It's 93% in non-responders. Again, with such high rates of response, there is no need to monitor the response. There is no need to decide what to do on treatment. You just treat your patient, you wait, and you will have a very small proportion of patients who will fail on therapy. So to conclude, I think we can say that HIV RNA levels must be measured by means of well-validated commercial real-time PCR-based assays with a lower limit of detection of the order of 10 to 20 IU per ml. Interferon-based strategies, including or not protease inhibitors, are response-guided. Thus, HIV RNA monitoring during therapy is key to tailor treatment duration. And finally, HIV RNA level monitoring might be less important in the future when all oral interferon-free regimens become available, but further studies are needed. And if you want to know more about viral hepatitis, you're very welcome to follow me on Twitter.